Now we have Dr. Soumya Narayanan. She is a consultant oculoplastic surgeon at Puttalat Eye Hospital, Calicut. She'll be speaking on animal bite and facial burns.
Good morning all. I will be talking on animal bites and facial burns. In both cases, the eyelids are more severely affected because of the blink reflex to protect the cornea. In animal bites, the most common injuries will be lid lacerations, canthal avulsions and canalicular tears. So the management include adequate wound toileting to like copious irrigation to remove the debris to prevent the wound infection, then the rabies prophylaxis and later the exploration and wound closure. So post-exposure prophylaxis for rabies should be given for mammals like dogs, raccoons, bats, domestic cats, fox, wolves, etc. And facial bites are classified as category 3 dog bites. So according to the CDC guidelines, we have to give 20 international units per kilogram of human rabies immunoglobulin around the wound, and if anything in the remaining has given us IM away from the site of vaccine. So about the vaccine, it can be given as intradermally or intramuscularly. In intradermal case, the patient has to come for 4 visits in the day 0, 3, 7 and 28. In each visit, he will be receiving 2 injections of 0.1 ml dose, mainly at the deltoid area. In case of IM, the patient has to come 1 more visit extra on 14th day, and each time single injection will be given either in the deltoid muscle or into the anterolateral aspect of the thigh. Along with the rabies vaccine, the patient has to receive tetanus vaccine and prophylactic systemic antibiotics. So initial surgical management focus on simple wound closure with the opportunity for a second stage procedure at a later time, because primary closure will give a healing time, shortens the healing time and decreases the rate of infection. And in larger defect, if possible primary closure, and if not, we can leave it for secondary intention healing and subsequent reconstruction. So about the burns, it can be caused by thermal, electrical, chemical or ionizing radiations, and the classification of the severity of the thermal burns depends on the degree of the structures involved. In the first degree burn, only epidermis is involved, so there won't be any blister formation. It will be a painful lesions and heal usually within 7 days without any residual scar formation. In second degree burns, it can be either partial thickness or deep partial thickness. In both, the entire depth of the epidermis is involved and part of the dermis is involved. And in both cases, there will be blisters, and superficial will heal within 2 weeks, but deep will take more time, like 1 to 3 weeks. So third degree burns, when there is full thickness of both epidermis and dermis, and usually because of the avascularity, there won't be much pain, but the skin will look dry, leathery, and there will be significant contracture. And if any structures below the skin is involved, like a bone or a muscle, it's called the fourth degree burns. For the assessment, first we have to take care of the life-threatening problems, and then ophthalmic evaluation should be done early, because otherwise the edema will settle in. Extent and severity of the lid injury, lid margin, lag of thalamus, Bell's phenomenon, and corneal condition should be seen. And if we are suspecting any foreign bodies, we have to do CT also. So the goal of the treatment is to protect the cornea and preventing the vision loss. Second is to control the contracture, and third is the secondary reconstruction. For the initial management, as we all do, head and elevation, cold compressors and copious irrigation, foreign body and debris removal, prophylactic lubricating drops and antibiotics and tetanus vaccine. So to protect the cornea, we can remove the eyelashes, charred eyelashes, and tarsorrhaphy or frost suture can be done to protect the cornea, and moisture chamber goggles can also be applied. In the first degree burn, we can, with all this management, it will heal. Second degree superficial, we can use collagen sheets. It will prevent shrinkage of the tissue. And second degree and deep or third degree, we can wait up to 3 to 4 days. So we will get a delineation of the burns, and then we can do layer by layer excision and skin grafting. All these will take care of the contracture, and also for the scar management, we can give silicone gel as shown by ma'am, and intralesional steroids and autologous fat. And late construction usually are done after 1 year, because there will be continued wound contracture. So the most common complication of periocular burns is ectropion, lid retraction and lag of thalamus. And if it is very small, we can do a full thickness skin graft and get away with that. And sometimes this will be severe and maybe involving both lids and all. In that case, we may require little bit of more reconstruction. So the most of the points of this talk is taken from the book by Dr. Bibasha Mukherjee, Emergencies of the Orbit and Agnexa. It's a must read.